Welcome to this lecture on ankle evaluation. We will move through the exam as a clinical decision-making process: history, observation, palpation, motion, strength, neurovascular screening, functional testing, and selected special tests. The goal is not to memorize tests in isolation. The goal is to decide what structure is likely involved, what findings raise concern, and whether the athlete needs referral, protection, or a progressive return to participation plan. By the end of this lecture, you should be able to complete a structured ankle evaluation from history through function. You should also be able to identify key bones, ligaments, tendons, and neurovascular structures, describe accurate setup and hand placement for major ankle tests, and connect findings to common patterns, such as lateral ankle sprain, syndesmotic sprain, deltoid injury, fracture concern, or Achilles rupture. Keep linking each test to the clinical decision it supports. Use this framework to keep the ankle exam organized. Start with history, mechanism, pain location, prior injury, and weight-bearing status. Then observe gait, swelling, deformity, and bruising. Palpate bone and high-risk structures before stressing the ankle. Next, assess motion, strength, special tests, and function as tolerated. Finally, decide whether the case needs referral, protection, modified loading, return to play restriction, or documentation for follow-up. The history tells you which pathway to follow. Ask whether the mechanism was inversion, eversion, dorsiflexion, external rotation, axial load, landing, cutting, or contact. Clarify pain location and whether the athlete could continue or take 4 steps. Ask about popping, giving way, locking, numbness, tingling, coldness, and swelling progression. Red flags include deformity, suspected fracture, open wound, neurovascular change, severe pain, Achilles rupture signs, and symptoms that do not match a routine sprain. Inspection begins as soon as the athlete moves. Watch gait, weight-bearing willingness, transfers, and guarding. Then compare both ankles from the front, side, back, and in weight-bearing. Lateral swelling after inversion often fits lateral ligament sprain. Pain higher over the distal tibiofibular area suggests syndesmosis involvement. A posterior gap or marked plantar flexion weakness raises Achilles concern. Deformity, rapid swelling, or inability to bear weight lowers the referral threshold. Palpation should be systematic and purposeful. Palpate bone before provocative ligament testing when fracture is possible. Check the posterior medial and lateral malleoli, talar dome, navicular, base of the 5th metatarsal, calcaneus, and proximal fibula. Then assess ATFL, CFL, PTFL, deltoid complex, AITFL, PITFL, Achilles, peroneals, tibialis posterior, tibialis anterior, sinus tarsi, plantar fascia, and pulses. Document the exact tender structure because location drives imaging and test selection. The Ottawa Ankle Rules help guide imaging decisions after acute trauma, but they do not replace clinical judgment. Radiographs are indicated when ankle zone pain is paired with posterior malleolar tenderness or inability to bear weight for 4 steps. Foot radiographs are considered with midfoot pain, plus navicular or base of 5th metatarsal tenderness or inability to bear weight. Urgent referral may still be needed for deformity, neurovascular change, open injury, Achilles rupture signs, or severe syndesmotic instability. ROM and strength help define severity and tolerance. Start with active dorsiflexion, plantar flexion, inversion, and eversion if tolerated, then progress to passive motion to assess end feel and pain behavior. Track where pain occurs, not just the number of degrees. Strength testing should include dorsiflexion, plantar flexion through heel raise when safe, inversion for tibialis posterior, and eversion for the peroneals. Painful weakness may suggest tendon involvement, inhibition, or poor stability after ligament injury. Every acute ankle exam should include a distal neurovascular screen. Check sensation in the superficial peroneal, deep peroneal, tibial, sural, and saphenous distributions. Assess active toe motion and ankle motion as tolerated. Ask about numbness, tingling, burning, or symptoms that worsen with swelling. For vascular status, Check dorsalis pedis and posterior tibial pulses when indicated, capillary refill, skin temperature, and color. Coldness, pallor, diminished pulse, or pain out of proportion requires urgent referral. Swelling affects pain, motion, muscle activation, balance, and test accuracy. Visual swelling helps with pattern recognition, but objective measurement improves follow-up. The figure 8 girth method is commonly used to quantify ankle swelling around the malleoli and midfoot landmarks. Measure both sides when possible and repeat with the same landmarks and tape tension. Rapid swelling can suggest more significant ligament injury or hemarthrosis, while delayed swelling can still affect progression and return to activity decisions. Functional assessment connects the exam to participation. Begin with safe weight bearing, standing, weight shifts, bilateral heel raise, and walking. Progress only as tolerated to single leg stance, single leg heel raise, squat, step down, jogging, hopping, cutting, and sport-specific tasks. Watch for pain, apprehension, antalgic mechanics, balance loss, dynamic valgus, and poor force absorption. Return decisions should reflect pain, motion, strength, proprioception, swelling response, and sport demand, not one negative special test alone. For the anterior draw test, position the athlete seated or supine with the ankle slightly plantar flexed and relaxed. Stabilize the distal tibia and fibula with one hand, while the other cups the calcaneus and posterior talus. Translate the talus and calcaneus anteriorly and compare side to side. Excessive anterior translation, a soft end feel, sulcus, or reproduction of lateral pain suggests ATFL injury. Guarding can limit accuracy, so interpret this with history, swelling, palpation, and comparison to baseline laxity. For talar tilt inversion, position the athlete seated or supine with the ankle relaxed, usually in neutral or slight dorsiflexion to emphasize the CFL. Stabilize the distal tibia and fibula with one hand and cup the calcaneus with the other. Invert the talocalcaneus complex while preventing leg motion. Compare pain, motion, and end feel to the opposite side. Excessive inversion or a soft endpoint suggests CFL injury or broader lateral ligament compromise. Remember, ATFL is stressed more in plantar flexion, CFL is stressed more in neutral. For talar tilt eversion, position the athlete seated or supine with the foot relaxed. Stabilize the distal tibia and fibula with one hand and cup the heel with the other. Evert the talus calcaneus complex while preventing tibial rotation. Medial pain, excessive eversion, or a soft end feel suggests deltoid ligament involvement. Because isolated medial sprains are less common, a severe eversion or external rotation mechanism should also make you consider fracture or syndesmotic injury. For the squeeze test, position the athlete seated or supine with the lower leg relaxed. Place both hands around the mid-calf or proximal lower leg and compress the tibia and fibula together. The key finding is pain reproduced distally at the ankle syndesmosis, not just soreness where your hands are squeezing. A positive test supports syndesmotic irritation or high ankle sprain. Interpret it with AITFL tenderness, mechanism, external rotation testing, and the athlete's difficulty with push-off or weight bearing. For the external rotation, or Kleiger test, position the athlete seated with the knee flexed and the ankle in neutral. Stabilize the distal leg just above the ankle with one hand and grasp the foot with the other. Externally rotate the foot relative to the tibia and fibula while monitoring the distal syndesmosis and medial ankle. Distal syndesmosis pain suggests high ankle sprain, while medial pain may suggest deltoid involvement. This test is most meaningful when the mechanism involved dorsiflexion with external rotation. For the cotton test, position the athlete seated or supine with the ankle relaxed in neutral. Stabilize the distal tibia and fibula with one hand, while the other grasps the calcaneus and talus. Translate the talus medially and laterally within the mortise. Excessive side-to-side motion, pain, or apprehension may suggest syndesmotic instability. Use this cautiously, especially in acute injury, and combine it with mechanism, swelling pattern, AITFL palpation, squeeze test, external rotation testing, and functional tolerance. For the bump or percussion test, Position the athlete seated with the legs supported. Apply a gentle axial percussion force through the calcaneus or plantar heel and monitor for pain transmitted to a focal bony location. Focal pain at the suspected fracture site increases concern for osseous injury and supports imaging or referral. This is not a test to perform aggressively. Ottawa criteria, focal bony palpation, mechanism, deformity, and weight-bearing status should remain central to fracture decision-making. For the Thompson test, position the athlete prone with the feet hanging off the table or kneeling with the ankles relaxed. Squeeze the gastrocnemius soleus complex and watch for passive plantar flexion. Absent or markedly reduced plantar flexion suggests Achilles tendon rupture. Also inspect for a tendon gap, swelling, bruising, weak push-off, and the athlete's report of a pop or feeling like they were kicked in the calf. Partial tears may still create some movement, so do not rely on one finding alone when suspicion is high. Use the pattern recognition matrix to connect findings. Inversion with lateral swelling and ATFL or CFL tenderness fits lateral ankle sprain. Dorsiflexion external rotation with pain above the mortise fits syndesmotic sprain and often recovers more slowly. Eversion or medial pain suggests deltoid injury and possible associated fracture or syndesmosis involvement. A sudden pop with weak push-off suggests Achilles rupture. Focal bony pain, deformity, or inability to bear weight raises fracture concern and should be protected and referred. Documentation should tell the clinical story clearly. Record mechanism, pain location, weight-bearing ability, prior injury history, swelling, bruising, gait, deformity, palpation findings, ROM, strength, neurovascular status, special tests, and functional testing. Then document your assessment, differential diagnosis, immediate care, referral decision, and return to participation status. Separate emergency referral, medical referral or imaging, protected management, and restricted return. Clear documentation improves communication and supports safer follow-up. In this case, the athlete lands on another player's foot and rolls into inversion. Lateral ankle pain and swelling, ATFL tenderness, mild CFL tenderness, painful anterior drawer with mild laxity, painful but firm talar tilt, normal neurovascular screen, and no Ottawa bony tenderness most strongly suggest a lateral ankle sprain involving ATFL with possible CFL irritation. Imaging is less urgent if Ottawa criteria are negative and no other red flags appear, but reassessment matters. Early care includes compression, protection, activity restriction, and progressive rehab. The key takeaway is that ankle evaluation is a decision-making process, not just a checklist. Start with safety. Rule out fracture, neurovascular compromise, gross instability, and Achilles rupture. Use history and pain location to choose the structures and tests that matter. Palpate bone before stressing ligaments. Interpret special tests in clusters with mechanism, swelling, ROM, strength, and function. Return to participation should be function-based and risk-informed, not based on a single test result. These references support the ankle evaluation concepts in this lecture, including lateral ankle sprain management, Ottawa Ankle Rules, referral decisions, syndesmosis screening, and orthopedic examination procedures. Use them to review test accuracy, clinical practice guidelines, imaging criteria, and return to activity principles. Evidence-informed care means connecting the literature with the athlete's mechanism, symptoms, exam findings, safety concerns, and sport demands.